Good afternoon and welcome to the MQ Mental Health Science Summit 2021 in partnership with Wellcome. If this is the first time you're joining us, thank you so much for coming along virtually. And if you're here for day two, then welcome back. Let me start by saying a big Eid Mubarak to everyone who's celebrating today as well. A few practical things for you as we move forward. We finished yesterday with a fantastic poster session, and I know a number of you went in to look at the posters that were in the space. A huge thank you to Cohen Veteran Biosciences for sponsoring the really innovative poster networking room. Cohen Veteran Biosciences are a great example of driving science and innovation for the benefit of people. Rethinking how we study the brain, redefining brain disease, and leading a systems approach to better understand the brain's basic biological processes. The standard this year has been fantastic in the posters, and if you didn't get a chance this afternoon or you didn't get a chance this morning to log in, then in the top right of your screen, if you click on the reception area, you can go in and view those posters. We will be handing out 2 awards for those posters, one that is given by the organising committee of the event, and one that you can vote for. So right now, if you scroll down to where the Q&A section is, where you can ask questions throughout the day, you'll also see there's a survey in there, and you can vote for the poster you think should win the audience prize. Do keep tweeting. We had some great reach yesterday. For those that saw, we had over 20 million impressions on Twitter with the hashtag MQ Science Summit. And a huge thanks to the whole mental health team for continuing to live tweet the 4 main sessions today. So do join in the conversation at any chance you can get. Moving into the third section of this year's summit, we shift our focus to children and young people's mental health. We know that 75% of mental illness begins before the age of 18. And despite this, studies based on MQ's methodology and international research say that only 30% of all mental health research funding is spent on children and young people's mental health today. MQ has seen this as a huge priority over its funding years, investing research into the Brighter Futures programme and calling for change, most recently through partnership with the All-Party Parliamentary Group on Fit and Healthy Childhood, looking at the impact of the pandemic on children and young people. We're delighted to see this week announcements of new funding for mental health and support in schools that will increase the support available through mental health advisors in schools, but we know that a lot more is needed. And from a research perspective, there's so much more that we need to continue doing. The recently published mental health research goals state for their first goal that they want to achieve research to have the number of children and young people experiencing persistent mental health problems. That is a huge goal to achieve in the next decade, and will need clear focus and leadership from the whole sector to see that become a reality. This section of the summit has 4 parts to it. Firstly, an active ingredients symposium sharing learnings and finding from Wellcome's first commission of projects on the active ingredients of treatments for anxiety and depression in young people. Then we'll have a Brighter Future symposium hearing about some of the research funded by MQ on children and young people's mental health. A keynote will then be heard from Michelle Krask, and finally we'll have a panel of lived experience young people sharing their thoughts and reflections on everything we've heard in this session. It stands to be a really exciting section of the whole agenda. So moving forward, I'll introduce our first 2 chairs who will lead us through the first section looking at active ingredients. They are Sebastian, who is the evidence lead of mental health at Wellcome Trust, and Grace Gatera, Wellcome Lived Experience Consultant, who we heard from also yesterday. I'll hand over to Kat and Grace now to take us through our first symposium.
Hello and welcome to this session on active ingredients for youth anxiety and depression. I'm Dr. Sebastian, evidence lead for Wellcome's mental health priority area, and I will be co-chairing this session with Grace Gatera, a lived experience consultant in our team. Together with Professor Miranda Wolpert, who will introduce the work in more detail shortly, I've been leading on our Active Ingredients Commission, focused on what works for whom and why for anxiety and depression in young people. I'm delighted that you can all join us today to hear from 5 teams out of a total of 30 involved in the Commission. The topics that our speakers will cover reflect the breadth of mental health science and include circadian rhythms, the role of the arts, digital social connection, SSRI antidepressants, and helpful thinking habits. I'm very much looking forward to hearing from all our speakers, and so at this point I will hand over to my co-chair, Grace Gatera.
Thank you, Kat. As a lived experience advisor and someone with lived experience, I am beyond honored and happy that I get to co-chair this session with my amazing colleague, Dr. Sebastian. What we are about to hear is almost a year's worth of hard work by dedicated researchers to better understand mental health science and to create a better world for people like me who face challenges being heard and understood growing up. I have the utmost privilege of introducing Professor Miranda Wolpert, Director of Mental Health at the Wellcome Trust, and an esteemed colleague to talk about the active ingredients. Over to you, Dr. Miranda.
Thank you. Thank you both, and it's a great privilege to be here. And you're going to really learn a lot from these 5 very diverse presentations. I guess my task really is to share with you the sort of wider vision that these came from. At Wellcome Trust, for those who don't know, we're a biomedical research funder. We give away about £1 billion a year to fund cutting-edge science to try and transform the lives of people with a range of health problems. One of the very great excitements of the last year has been that Wellcome has announced that mental health is now one of only 3 things it will be focusing on going forward. So we stand shoulder to shoulder with a focus on the health effects of climate change and infectious disease. And I think I'm right in saying we're the first global funder to prioritize mental health in quite this way. So it's really exciting. And this work really is the start of a journey that we are going on to try and transform and create a world in collaboration with all those watching and others out there that will mean that people are no longer held back by mental health problems. And that might mean for some people finding a cure. It might mean for some other people finding ways forward to manage or deal with ongoing or relapse and remitting difficulties. And we're open to that full panoply of opportunities and options. And one of the excitements of this active ingredients approach is saying Wellcome will do forward translation. We'll look at basic science, whether it's in mice or molecules, cellular or at any other level, and we'll try and understand from that what might be exciting interventions going forward. But we'll also do back translation. We'll try and work from, okay, what seems to be working, whether it's SSRIs or green space or different ways of thinking, and we'll try and look back and say, okay, how do we understand that? How can we learn from that to try and develop new and innovative interventions? So currently we're focused on youth anxiety and depression, but going forward we will have a wider remit which will be both youth and adults, and will also include psychosis. We've got a current commitment of £200 million over the next 3.5 years, but that will grow as we continue, and we now have a 30-year ambition in relation to mental health. So really excited to be here today. Unfortunately, I have to drop off straight after this, but I'm coming back this afternoon. So I'm not here to answer questions, but I'm going to be joining later and really looking forward to what people have to say. And with no further ado, I'm going to hand over to our speakers who are going to actually present the exciting findings from their work. Thank you.
Hello, I'm Professor Hickie, the Co-Director of Health and Policy at the Brain and Mind Centre of the University of Sydney. And it's my pleasure today to have the opportunity to present to you work that we've been doing in association with the Wellcome Trust funding on active ingredients for enhanced treatment of young people with depression. Our focus has been on circadian sleep-wake cycle disturbance and its implications for early intervention, indicated prevention, and more effectively secondary prevention of this important set of disorders. It's an area of very active research, and while I won't have time today to cover all of these areas, there are many things happening in the characterisation of these rhythm disturbances in young people, what happens longitudinally, what are the relationships between the circadian systems internally and their external drivers, and what's the potential to harness the really enhanced understanding of this aspect of neurobiology in its environmental context to translate to better treatments. Basically, what are the key developmental pathways that are underway here? When, how do we intervene best? Early intervention, secondary prevention for enhanced outcomes. Circadian medicine has become a very important topic in recent years, subjects of Nobel Prizes, subjects of much basic science, much greater understanding of its implications across a wide area of medicine, in metabolic disease, in cancer, and very importantly, in neuropsychiatric disorders. As we see greater elaboration of the basic science, the hypothalamic nuclei, its relationship with other brain systems, melatonin, orexin, classic monoamines, we can start to record the phenotypes that are relevant, the outputs, the downstream effects, back through the hypothalamic pituitary system on stress response, back through the metabolic disturbances on things like weight gain, cardiovascular performance, really important to the long-term physical health outcomes as well of young people with these types of depressive disorders. There's a long history of investigating circadian rhythm disturbance and depression in general. Most of the work done in older populations, middle-aged populations with depression. Our own work for some years has been very much focused on younger people and elaboration of these disorders in the early onset groups that we see through our national early onset and early intervention frameworks in Australia in primary care, the so-called headspace networks. So we're lucky in Australia to have a clinical focus on this, as well as longitudinal twin studies and others focused on the adolescent period. The fundamental question for us is how many causal pathways actually result in depression in young people? And what's the best way of tracking that in terms of developmental trajectories across childhood into adolescence? What sorts of problems actually are captured under the notion of adolescent onset of depression? And what are the implications for the underlying neurobiology and optimal management? So in particular, we focus on three different types: anxious depression, what we call the circadian bipolar spectrum, and neurodevelopmental difficulties. The one we've emphasised in this active ingredient is that related to the circadian system, its development in childhood, association with rhythms of sleep, of attention, of feeding, but in the adolescent years are much more associated with dysregulation of the sleep-wake cycle, associating themselves particularly with depressive disorders, although particularly also with other representations, which may include brief periods of hyperactivation. Overwhelmingly, interestingly, in terms of mood states, that associated with low energy and fatigue than necessarily with depressed mood. We're trying to map that onto developmental pathways that are happening within brain systems, but also within the response systems, hypothalamic pituitary, circadian being the classics, but also immune and metabolic. And then what are the external factors? What are the things that we can actually make use of to actually either prevent, intervene early, or enhance the outcome? So our prior work had really focused on the extent to which sleep phase delay is common in this particular period, to which there's a normal shift towards going to bed later and getting up later, but the extent to which those with mood disturbances have further delay, they have a so-called atypical depression profile, very much associated with low energy, and the extent to which they may gain weight and have a dysregulation of the circadian system as the primary driver, rather than the classic stress arousal type concept. In combination with the focus on the circadian system is one that we've really pursued with our colleague Pat McGorry here in Australia, which is clinical staging. What are the features early in the course of illness? And if you intervene earlier, can you achieve a better outcome and better long-term secondary prevention of recurrence or progression to more severe illnesses? So our best bet for a specific active ingredient, as funded by the Wellcome strategy here, was to focus on that disturbance of that 24-hour system, not just sleep, not just activity, not just wake, but the whole 24-hour system and its underpinning neurobiology. What we're really trying to do is pick up people at earlier stages, get them out of the holes earlier, then provide the secondary prevention strategies that may be particularly relevant. Here, if it is a circadian driver, what are the factors psychologically, behaviourally, medically that get you out of the hole quicker, but also give you the best chance of secondary prevention so you do not progress to more severe illness phenotypes. So the bottom line of what really matters here in terms of changing that system. First, number one, light exposure. Time of day, dose of light, inappropriate exposure during the nighttime period. Interestingly, in our lived experience group with young people, these particular strategies that I'm now talking about, their sleep-wake cycle, were rarely discussed, in fact, with young people when they're being asked about their depressed mood, and rarely asked about key factors like timing and dose of light exposure. timing and dose of motor activity. And very important work that we've done with Kathleen Merikangas from National Institutes of Mental Health. We'd focused on the extent to which energy and activity are the drivers of mood in any subsequent period. And if you want to know what is happening, you can record it increasingly with various activity-based devices to give much feedback of the association between motor activity and energy and subsequent mood. If you want to improve your mood, be more active. You want to change the way you're feeling now and be more energetic, increase the amount of activity. That mood is a consequence, not a driver of much of this area. And you need to look at that in particular epochs across the course of the day. Thirdly, there are appropriate psychological strategies that become relevant in this particular area, and how you look at issues related to ruminations, how you look at issues in relation to timing, how you look at issues about arousal in the evening in terms of anxiety before sleep, and particularly how you look at the behaviourism of this and the thinking patterns that go with it to maximise the outcome. There's been quite a lot of work in the insomnia area in these areas, but far less work on really the appropriate behavioural and cognitive mix to maximise the total 24-hour sleep-wake cycle, and the extent to which people can have the experience that by changing their behaviour, they can actually change their mood and certainly their energy during that particular period. When people do come to medication, we've been particularly looking at the issues related to melatonin as distinct from the classic serotonergic agents. Interestingly, this is one of the areas where SSRIs and the classic serotonergic activities medications, and those which is classically called first line for teenagers, may make the situation worse, not better. A lot of our experimental work is looking at whether melatonin-based agents, melatonin itself, melatonin-based antidepressants may actually be associated with better outcomes. And certainly there's preliminary evidence in that area, but much to be done to work it out. It's not an area where a medicine alone will fix the problem, but medicines used smart in association with the right behavioural and timing strategies may make an enormous effort. Lastly, there are a whole range of experimental medications that are underway. So some in relation to the ketamine type areas and their effects on circadian pathways, particularly directed to the work of Carla Serrati at the National Institutes of Mental Health. And then, of course, what is happening in the orexin area, another area that's been identified in recent times, coming really out of narcolepsy work and elsewhere, and the development of new agents to suppress the orexin system, trying to get the 24-hour system right as to when you're most active and when you most sleep effectively to actually have the optimal sense of well-being in these areas, and the extent to which depression in adolescents, at least for a significant subpopulation, is driven by these factors. So our real task is the extent to which we can use these 5 factors that are actually out there in individuals to get optimal treatment early of their depressive episode, if it is of this type, to characterise it phenotypically, work with individuals over time to see the associations that we would predict, and then become more empowered to take this forward. In the work we've been doing with young people most affected, they've been incredibly enthusiastic about joining this in. And in work to come out shortly in Lancet Psychiatry, both describing the lived experience and the summary of this work, you'll see that combination. We think there's a great opportunity here, at least for a significant subpopulation of those with adolescent depressive disorders, to get more effective treatments earlier in the course of illness with greater potential for secondary prevention. This is work that's really been fundamental in our area, now taken forward in association with the Wellcome Trust Special Initiative for Active Ingredients. Very much thank our lived experience participants led by Sam Hickie and our other contributing academic centres, not only here in Australia, but also in North America with Kathleen Merikangas and in the United Kingdom with Jan Scott. Thanks for your attention.
At Sumunum, our world revolves around well-being. It also revolves around art. Our primary focus has always been mental health, particularly among young people. And we do believe that art matters. There is evidence on the efficacy of arts interventions on mental health, but we need a detailed synthesis focused on modalities of functioning, particularly with regard to youth. In 2020, the Wellcome Trust Active Ingredients Commission gave us an opportunity to explore this. Can art help prevent and treat youth anxiety and depression? We wanted to understand what works, for whom, where, and how. We designed a participatory insight analysis that combined a scoping review and multimodal arts engagement to work with young people with lived experiences of anxiety and depression. There were more papers than expected. 36 studies finally fit our inclusion criteria. The diversity in approach, conceptualization, and execution of art interventions stood out. The umbrella term art intervention did not capture modalities and approaches or reflect the underlying processes used to facilitate non-judgmental and enabling spaces for expression. So, we analyzed the intervention descriptions across the 36 included studies and arrived at this set of 9 key ingredients. These contribute to positive mental health gains for young people with depression and anxiety. Studies indicated a range of benefits. The reported effect sizes from studies that were RCTs or NRCTs show that the mean differences are at least over 0.5 times the pooled standard deviation on scales measuring depression and anxiety. Effects were more pronounced in measures representing allied psychosocial resources. However, it was challenging for us to extrapolate exactly what works, for whom, where, and how from the current evidence. In most studies, sample sizes were small with no longitudinal follow-up. Interventions were predominantly short-term, with the length ranging from a single session to 30 over 2 to 6 months. What was jarring was that there were almost no youth voices present. Despite references to participation, none reflected youth voices in service planning or research. The approach to care and intervention planning was largely biomedical. Arts interventions were inserted into therapeutic frameworks without consulting arts practitioners. As the research team combed through existing evidence, our arts team initiated the multimodal arts intervention. Our arts engagement sessions were strengths-based and designed to create a safe space for young people to discover their own vocabularies, to articulate and express mental health needs. Spread over 2 months, the 60-hour online guided arts activities included drama, poetry, visual art, and movement. We called ourselves the Sumunum Circle. Majority of our youth advisors had early negative experiences with mental health services and found them to be top-down, specialist-driven approaches. They expressed experiencing a sense of loneliness and an inability to express themselves for fear of judgment.
I'd like to know how and when do I have to seek help?
How you can approach, or what we can do to ask for help.
To spread the awareness that it is not a taboo.
In this regard, they reported finding strength in the collective vulnerability of a group that came together through art.
There's a huge change. I am a lot more calm, a lot more centered.
This has helped me identify, choose to respond instead of react to the people around me.
I've started being vulnerable with the people in my life.
That basic feeling to know that there is someone to help you was a huge takeaway for me.
In the Indian context, the influence of caste, gender, sexuality, and particularly understanding and accepting diversity were highlighted as defining influences on mental health. They felt strongly about redefining and renegotiating not only psychiatric diagnostic labels, but also medically driven understandings of emotion, health, and illness. Our youth advisors advocated for a holistic approach to mental health and called for early intervention that places the young person at the center of the decision-making and care process. They advocate for integration of arts interventions into existing education and mental health care systems.
Throughout my school years, if there had been someone we could have talked to, I know so many people, including myself, that would have benefited from it.
Have these conversations at a young age, at a formative age, than have to deal with them at a later stage where the damage is significantly greater.
The findings from our scoping review echoed our youth advisor perspectives. Art interventions were found to be feasible with predominantly positive effects on depression and anxiety amongst diverse youth populations and settings. However, they are not feasible for use in active conflict settings and may not be appropriate for youth with severe illness presentations. As a practice-based organization, we felt compelled to channelize existing evidence and use our own experience as a springboard to create a service package. We, a team of mental health professionals, arts professionals, and educators, put our heads and hearts together to devise a school-based program. We created Openmind, an arts-based social emotional learning program. It is designed to enhance social emotional awareness, increase self-esteem, and self-efficacy. Most importantly, it is aimed at helping young people articulate their mental health needs, gain awareness of their internal and external resources, and inculcate positive help-seeking behaviors. We piloted the online version of Openmind late last year. It is too early to know the efficacy or effectiveness of the program. However, it does seem to be feasible for implementation. The acceptability of the intervention was high at our pilot site, but requires evaluation across diverse geographies and populations.
They've forced me to re-examine or to question some of the personal biases that I've had. I can be a much more sensitive person. I'm able to understand people a lot better and to understand where they're coming from.
Feedback from students indicates the urgent need for support and for interventions like this. Openmind is being refined and will be evaluated for effectiveness soon. In India, where there's a dearth of research and interventions that address youth mental health needs, we hope to build practice-based evidence and a resource-effective, scalable intervention. We asked our youth advisors for some final thoughts and a wishful note to their younger or older selves.
It's gonna be okay.
Get help and ask for help and talk to people in her life. Don't be so scared.
Your mental health and your peace of mind are a lot more important than what others think of you.
Learn from your lessons.
I hope you're taking care of yourself.
I think when you build a system on kindness and not a system that kind of punishes you for not following the rule, that really helps.
I love you, I guess.
Our deepest gratitude to Wellcome for supporting this inquiry, MQ for having us here today, and to all the lived experience experts who were so candid and giving of their time and experiences.
Thank you, Kat, and thanks for inviting us today. I'll be speaking today together with 3 young people from our 9-person young person advisory group who are part of our team throughout our project. We will talk about our scoping systematic review on quality social connection in digital interventions as a possible active ingredient for youth depression and anxiety. I'm Lindsay Dewa, and I was the lead researcher on the project.
Hi, my name's Emily, and I was one of the 9 people involved in the advisory group, and particularly in the data dissemination process. So definitions are mixed and often confused with the quantity of our connections. However, in this context, we're talking about the perceived attributes of an interaction between 2 or more people. So feeling a part of something larger than yourself, feeling close to another person or group, feeling welcomed and understood, and alternatively, it is described as a therapeutic alliance when undergoing psychotherapeutic treatment. Social connection is a key protective factor and mediator in outcomes for anxiety and depression across each stage of the care pathway. For example, it can help reduce loneliness, help lower levels of anxiety and depression in young people, and mortality is reduced. Digital interventions can facilitate connection. However, it is unknown whether the effects remain digital, and if so, what helps to achieve this. Establishing the benefits and risks of digital interventions compared to face-to-face, and whether this changes when human interaction is removed, was identified as a top research priority in digital mental health. Our aim was to find out if using digital interventions helped with the outcomes for depression and anxiety, such as social media, smartphone apps, chat rooms, and other types of social connection. We used a systematic scoping review and a meta-analysis, as well as looking at different contexts, people, and their use of digital mechanisms from all over the world. Young people were also involved with this with all aspects of the study, which allowed them to feed in valuable opinions and feedback. Ellie will now take you through this process.
Thanks, Emily. Hi, my name's Ellie Brooks-Hall, and I was one of the young people involved throughout the project, in the workshops and the dissemination, but particularly in the literature review. Building on the team's experience of working with young people with lived experience of mental health difficulties, they advertised for a new advisory group for the project, and 9 young people, including myself, joined the team. We worked collaboratively throughout the project, and I personally felt like we were really listened to and valued across all stages. One example of our involvement was during the design phase, where we held online workshops with our entire team and separately with the young leaders of the Lancet Commission for Global Mental Health. We helped to refine the definitions for the review, including that of social connection, the areas of focus, and the search terms. As I mentioned, I was also involved in the entire literature review, acting as a second reviewer and checking through the screening, quality of the studies, and what study information to extract. Nathan, who you'll also hear from in a minute, was involved in interviews with a mental health ambassador as part of our dissemination phase as well. So as you can see, it was really inclusive throughout the whole project of our opinions. Young people from our team also informed the review findings, identifying what indicators of social connection were missing to eventually inform a conceptual framework, which Lindsay is now going to talk you through and identify what's needed in the future.
Thank you, Ellie. So I appreciate this is a really busy slide, so I'll do my best to do the main points. We found 42 studies that mainly had cross-sectional design from developed countries, primarily the USA, and that covered treatment and depression and prevention as opposed to treatment or prevention on their own. Digital interventions massively varied, but included social media, such as Facebook and Twitter, apps, and apps specifically for mental health, online forums, and actually mental health sort of interventions such as cognitive behavioural therapy online. Social connection overall was related to improved outcomes in almost all studies, particularly for depression and anxiety to a lesser extent. Digital mechanisms that helped ensure this connection included anonymity, peer support, and ease of access, whereas possible harassment and disconnect from the real world were mechanisms that actually hindered this connection. Young and professional experts felt that indicators such as trust, safety, and seeing body language was particularly important for social connection to be present, but actually were largely missed from the literature. This resulting framework that you can see here, called RIVER, has 5 main components of social connection: rapport, identity and commonality, valued interpersonal dynamic, engagement, responded to and accepted. And each one of these had subsequent indicators that were found from the young and professional experts and the literature.
Thank you, Lindsay. Hello, I'm Nathan. I'm one of the young people that was involved in the workshops, and I was also able to add a few personal touches to the dissemination artifacts. So we've established that having a social connection when using digital interventions does seem to have a positive impact on depression and anxiety to a lesser extent. Future research could therefore transform this RIVER framework into a standardized measure to evaluate the presence of social connection on the outcomes of digital interventions and to put the framework through its paces. There also seems to be enough evidence to suggest that quality social connection is a key consideration when designing digital interventions, although future research does still need to account for the effect of preference differences, delivery style, anonymity, and content moderation, for example. Social connection is so important to all of us, and clinicians, educators, and peers need to understand that to get the best from any interventions. This could mean that new guidance and training is considered to ensure that therapies and informal social connections are not affected during the COVID-19 pandemic when face-to-face contact is limited.
Thank you, Nathan. And we just wanted to finish with some project reflections. We have now added to a very limited evidence base on patient and public involvement in systematic reviews, as opposed to what it was before, which was actually really limited, and ours is actually added to it. We've shown real big impact involving people with lived experience can have on a topic area and on the review itself. I would definitely work together with young people with lived experience in the future on subsequent reviews. Over to you, Ellie, for your reflection.
Yeah, I totally think that's true, Lindsay. I have never, as a young person, been asked to be involved in the quote unquote more academic bits of a study, like literature reviews, and having that opportunity was a massive deal to me personally, professionally, wanting to go into psychology myself, and it felt like it meant that our voices as young people were really valued throughout the whole study.
Yeah, I completely agree. I really love this push for patient and public involvement, and I think it's so, so important.
I totally agree with you both, and I definitely think this young person group allowed so many people to get insight into mental health research, which they haven't been able to have before.
Thank you to everyone that worked on this project then, including our wonderful experts, researchers, and our 9 young people. To echo what we've all said, we're so lucky to have their voices, and I was very, very privileged to be a part of it.
Good afternoon. It's a real pleasure to be here and share with you the insights that we've gained as we've reviewed the literature about the use of antidepressants in young people. We're really grateful to the Wellcome Trust for funding this research. I'm Susanna Murphy and I'll be presenting alongside my colleague Catherine Harmer. Depression and anxiety are common in young people, and for those who experience severe disorder, the impact can be devastating. For this reason, early and effective intervention is critical. Rates of antidepressant use in young people have risen significantly over the past decade, but despite this, very little research has been done in this area. Most research has been focused on adults, and it's been assumed that the same will be seen in young people. However, there are quite profound differences in brain organisation and structure, and really important developmental processes in terms of cognitive, social and neurodevelopment that occur during these critical years. As part of this project, we consulted with a group of young people who had lived experience of depression and anxiety, many of whom had experience themselves of taking antidepressants. We held a series of online workshops, and the insights that these gave us really challenged us to think about the complex decisions that are faced when a young person considers taking antidepressants. I'm going to play you a clip now from one young person where she talks about her experience of starting to take antidepressants.
I've been taking antidepressants for about 6 months now. At the start, I felt a bit sick. I couldn't really eat food, and I think that is a big thing that needs to be considered, is the side effects. I was a bit nervous about making my anxiety worse, but now that I'm sort of stabilised on them, they're just so much better for my life. I can actually do stuff, which is very nice. Obviously, you still have down days, but they make the down days a lot less frequent and make them bearable.
One of the messages to come out from this account is the idea of having to balance risks and benefits. So what about the potential benefits? Well, the most obvious benefit of antidepressants is their effectiveness. Clinical trials of SSRIs in young people demonstrate that, compared with placebo, SSRIs are an effective treatment for both depression and anxiety. The highest quality studies are those that have been publicly funded, and they've compared antidepressants against both placebo and psychological therapies, such as CBT. And in depression, the biggest study of this kind showed that SSRIs, either given alone or in combination with CBT, were more effective than placebo and more effective than CBT alone. Interestingly, this study demonstrated that combining SSRIs with CBT was a particularly effective approach, and this supports current clinical practice and guidelines recommending psychological treatment should be given alongside antidepressants. So what about the potential risks? Well, as you heard, antidepressants have side effects such as nausea and headaches. Luckily, these tend to be quite transient, but perhaps more concerning is the potential for longer term effects on development, and this is currently very poorly understood. There's also the concern that perhaps SSRIs have the paradoxical effect of increasing suicide risk, which comes from the observation from clinical trials that SSRIs can be associated with an increase in suicidal thoughts and behaviours. This risk needs careful management clinically and needs to be balanced against the risk of not adequately treating severe depression, which itself carries significant suicide risk. And this highlights a central message from our review, that the possible risks of SSRIs need to be carefully balanced against the risk of not properly treating these disorders in young people.
Thanks, Susie. So the next question we asked is how SSRIs may work in young people with depression and anxiety. The work which has been done in this area is rather preliminary, but we are beginning, I think, to see a pattern of how SSRIs may work, not just at the brain and chemical level, but also at a psychological level, as you can see in this diagram. So we know that SSRIs increase levels of serotonin in the brain, and that this initiates a whole cascade of effects which may be relevant to treatment. From modifying the function of corticolimbic brain circuits, which have been assessed in fMRI studies, to then increasing our ability to regulate emotions and reduce emotional reactivity. And this has been assessed both in neuropsychological tasks and in patient report. And so then these effects may go on and modify responses to stress and other life challenges in interaction with the individual's own environment. And some of these mechanisms have also been highlighted with other types of intervention as well, including psychological treatments, therefore suggesting some really interesting parallels in treatment action across different disciplines and approaches. Next slide, please. It was quite clear from our review of the literature, though, and our discussions with the young people in our workshop, that there was a significant gap between the use of SSRIs and how little we really understand about their effects, specifically in young people. There were particular concerns about the possible longer-term effects of taking SSRIs during adolescence, something on which there's very little research and evidence to draw on directly in humans. The effects of coming off SSRIs are also poorly understood, and therefore it's hard to best know how to manage this process. Another key question was the potential effect of SSRIs on schoolwork, ability to concentrate, and other areas of function really important to young people, but which may not be assessed directly with current symptom scales. And we found that despite there being quite a lot on different treatments for young people, there was little research on how to best bring these together, something that we felt having an understanding of the mechanisms underpinning treatment effects and greater interdisciplinary working may help to facilitate. And so, to summarise and conclude, rates of SSRI use in young people are increasing faster than our understanding of these treatments in this age group. There's lots of outstanding questions, and a focus on mechanisms of effective treatment may be a useful way to start addressing some of these gaps. We really need to know why, how, and when they work to progress treatment of the future and to reduce trial and error in our development of new and current treatments. And finally, just to acknowledge the whole team involved in this active ingredient review and the young people advisory groups, which really helped us to understand these key questions and experiences. Thank you.
Hello everyone, I'm Jennifer Lau. I'm at King's College London, but from July we'll be moving to Queen Mary to co-lead the newly funded Youth Resilience Research Unit. So within this broader programme of research, our focus has been on whether or not the promotion of helpful cognitive patterns can prevent or treat youth anxiety and depression. So helpful cognitive patterns are an umbrella term for beneficial ways of processing information in the environment, and it includes the capacity to flexibly shift attention towards positive or neutral over negative information, and the capacity to generate, endorse, and select positive or neutral interpretations of ambiguous information over negative ones. So why this focus? So young people that we consulted say that that unhelpful cognitive patterns are present in daily life. So this is an example of an unhelpful attention pattern. If I'm in a group setting and I say something and everybody laughs except one person, I will focus on the one person who doesn't. And this is an example of an unhelpful interpretation pattern. Say if I'm working on a project as part of a group and I'm responsible for certain parts, if I present what I've designed to my group members and they don't say it's really good, then I will think it's not good enough. Inconsistent with developmental cognitive science findings, young people say that these unhelpful cognitive patterns can maintain symptoms of anxiety and depression. So, for example, this young person said, "It makes me feel more depressed. I withdraw myself from other people and I don't want to talk to anyone." So what we were interested in here is that if we can find strategies to encourage helpful cognitive patterns, then perhaps we might be able to reduce youth anxiety and depression. And we address this by a systematic search of the published literature. And we synthesized data from about 80 papers. So we synthesized findings from 80 published papers. We were also interested in how we could enhance the benefits of these strategies for encouraging helpful cognitive patterns and what the remaining challenges were. So we addressed this by consultations with 10 young people with lived experiences of anxiety and depression, aged 15 to 24 from diverse backgrounds. So the findings from the systematic search suggested that there were two main methods for encouraging helpful cognitive patterns. The first used computerized training methods to reinforce helpful attention and interpretation patterns through repeated learning in the hope that these would become habitual and automatic. The data suggested that these training paradigms were largely effective at changing attention and interpretations. However, the translation into reducing anxiety and depression was weaker. And we wondered whether or not by co-designing some of the content and materials for training with young people could increase their appeal and engagement of young people and therefore increase these symptom reduction effects. The second set of methods were through clinical instruction, usually with a trained practitioner. So these included therapeutic techniques such as attention flexibility training, where you might train individuals to attend to different sounds in the environment, to focus in on one sound over another, and then to shift attention between sounds, and also cognitive restructuring, where of the same situation, you would generate alternative interpretations of the situation and try and find pros and cons of each interpretation in order to come to a more balanced interpretation. For these kinds of techniques, there was a clearer reduction of anxiety and depression symptoms. However, because these were usually embedded in the context of larger cognitive behavioral therapy programs, and also because many of the studies did not measure attention and interpretation patterns, it was hard to attribute any symptom reduction effects to these mechanisms. The consultations with young people suggested that perhaps if you challenged both attention and interpretation, you could enhance their benefits. So this young person said that I find it easier to engage the negative thought a little more, so attending towards it, and then challenge the idea in my head. So using, for example, cognitive restructuring. This young person suggested that if you bring to mind positive details about yourself or about other details in your life, that might also enhance benefits. So I write down things I appreciate about myself. So say if I cooked dinner for my friends and they didn't give me positive feedback, I might assume that my cooking wasn't good. But then if I wrote down that I actually cooked for them, then I might feel better. But young people also said that there were continuing difficulties using these strategies. So in counselling, they try to think about all the positive explanations before you jump to negatives. If I can recognise it is happening, this can be easier, but very often I don't, so it doesn't help massively. So in summary, more work is needed to enhance the symptom reduction effects of computerized training, and also more work is needed to establish whether or not clinical instruction methods involve changes in attention and interpretation. However, if successful, these different methods for challenging unhelpful thinking patterns and encouraging helpful thinking patterns could be a more cost-effective and accessible strategy, particularly in low-resource settings. So to leave you with a final study that we recently completed, we trained helpful attention and interpretation patterns in 76 young people rescued from illegal labour in India and Nepal. The intervention protocol was feasible in that there was high recruitment rates and high retention rates, and sessions were also acceptable in that the majority of young people rated themselves as being moderately or highly motivated to complete training sessions. Thank you very much.
I think that you will agree with me that this has been an informative session. I have learned a lot personally, but I think that my favorite of these presentations was the short notes to the future self activity that Sumunum Arts did with the lived experience experts. I must remember to do one for myself at some point. It really, I felt like it touched a part of me. Without further ado, actually, my first question will go to you, Kamala. Did you notice any difference when you were taking the lived experiences, the lived experience experts through these activities? Is there any marked or like logged difference in between when you started and at the end?
But Kamala, did you hear Grace's question?
Sorry, Kat, I had a little bit of a patchy internet issue here at the moment, so I didn't hear that. But Grace, if you could just repeat that once, please.
Right. I was talking about how much I enjoyed the notes to the future self activity that the lived experience advisors or experts did. And I asked if you had seen any marked difference between when you started your work and at the end.
Thank you so much for sharing that. And to answer really quickly, I think we did, particularly in engagement and levels of sharing initially vis-a-vis what happened at the end of the intervention. The young people who started off, when we started with the intervention, there was a lot of hesitance in actually sharing personal stories or just being involved in the circle, but it took a lot of time and a lot of flexibility with regard to the nature of engagement. For instance, even the flexibility to keep your cameras off, or, you know, just attend the sessions but not engage if you didn't feel like engaging. But, you know, everyone reported just taking something away just with that knowledge of being there. So thank you so much for asking.
And I wonder, we don't have much time left, but I just wanted to open up that question perhaps to one of the young people who was involved. What did you learn over the process?
I think the person on Lindsay's study about digital interventions, and I think I massively learned things about myself, as cheesy as that sounds. It was definitely like doing this research into like the other people have these feelings, and knowing that like they were looking into these interventions genuinely helped me to kind of come to terms with my own feelings, I think. And also, like I said in my presentation, being involved kind of in that professionally was great.
Thanks, Ellie. Unfortunately, we've now run out of time, but I'm very grateful to all our speakers today and to all our commissioned researchers and lived experience consultants for engaging so positively with our Active Ingredients Commission. In addition to these talks, you will find more of our teams represented in the posters, So please do go and check them out during the break. Thank you so much for coming to our session today to hear about our work at Wellcome.